So welcome, uh, Dr. Batiste and Dr. Pai.
Thank you.
Thank you. Um, if each of you could just give a 1-minute summary, you might have already done it to another audience, but just to briefly tell everyone what you've been doing for the last 5 years, just so and then I'll start asking you questions. Dr. Pai, you want to go first?
So in the last 5 years, well, since I've been on this program for the last 5 years as well. So thank you, Stephen, for inviting me back. But it's really just keeping up with the evidence in the literature of looking at prevention and treatment and reversal of diseases, predominantly using diet and lifestyle, right? And in our clinic, we work on epigenetic factors: diet, lifestyle, environment, belief system. And so we take patients, and just like with my book, An Inflammation Nation, we take people through 10 steps. So that's what we've been doing. We just continue to follow our patients. But we always have to modify and adapt. So what's been changing over the last 5 years in my practice is more data information coming about microbiome and better nutrition analysis and testing, and looking at other things now with like environmental toxicities and things that everybody, regardless of what we eat, are getting exposure to. So it's kind of modifying those things. And also just from the medicinal side and formulation is that we'll be having 4 products coming out this year that are evidence-based, patented, run through clinical trials, published, peer-reviewed, and then even those formulations of those patent ingredients, that formulation will be patented as well. So we're kind of moving what I look at as taking the natural therapies, the ancient wisdom and the pharmaceutical science, but then also kind of delivering it like a pharmaceutical as much as we can, because people want to get evidence-based outcomes, and they also want to get clinical efficacy. Safety and efficacy is what we need to show. And efficacy is something that's always, as you know, lacking in the dietary supplement industry. And so for us, it's like when we do something or we recommend it, we have to have enough strong data and the right potency, purity, safety, efficacy to do that. So that's what we've been doing over the last couple of years.
Thank you.
That's great. Well, I haven't been doing anything quite as remarkable as Dr. Pai, but
He's saving people's lives.
But day in, day out practice, as well as trying to really help structure inside my multi-specialty medical group, lifestyle, embedding that in terms of cardiovascular disease, looking at not just nutrition and exercise, but also, as Dr. Pai mentioned, in terms of the mental aspect and looking at mindfulness and stress reduction are the major components that I'm trying to really embed in the program, where you have not everyone is like-minded. So that's an aspect professionally, along with my clinical practice, along with my community work. We're still out there doing the work, boots on the ground. We have had contracts in terms of going into barbershops and churches and communities at risk, performing blood pressure screening, nutritional education, and really hoping to spur transformation. We have launched, the organization has launched a conference where we actually come together and look at like the latest evidence as it relates to nutrition, but then also looking on a practical boots on the ground level, how we can implement this in the communities that are in need. That, I think one of the driving forces for our organization is that we want to be a light in darkness. We're not trying to be a light amongst all the other lights. Like, what good is it just to have a bunch of applause from everyone who recognizes what you're saying? But really, I want the naysayers out there. I want the ones who are not, where it's not a debate over small nuances. It's an issue of major transformation. And that's where I'm gleaning my satisfaction, my meaning, my purpose in life.
Thank you. Okay, so I'd like to run through a lot of questions. So 1-minute answers would be good. Otherwise, if we spend too much time on one answer, we'll end up not getting to most of the questions. So although there's a lot that you could say on each question, it would be better if we could keep them to focused 1-minute answers so I can move through an extensive list of questions. Starting, Dr. Batiste. You mentioned the impact of stress on the endothelium. How can individuals work to improve their endothelial function? That's the question, yeah.
So that's a long answer, but I'm gonna summarize it this. I believe that health and endothelial health is simply resiliency divided by stress. So we can't eliminate the stresses of life, whether or not that's financial, if it's relationship, if it's politics, if it's nutrition, if it's pollution, if it's noise. All those things can impact our endothelial health as a form of a stressor through oxidative stress and then cause impairment. when we focus on the resiliency in terms of how we're sleeping, are we trying to get sleep? Are we trying to get as much fresh air? Are we trying to get exposure to green areas, green spaces? Are we trying to feed our bodies with health promoting foods that can promote nutritional resiliency? That's where we get empowerment. That's there. And and once we do that, we begin the process of making sure that our efforts, we're investigating our efforts. And that may be through our blood pressure, that may be through our cholesterol level tests and variables that are there and other nuanced tests to help give us some of the information that we need. I think that was a minute and under.
Okay, thank you. Um, uh, uh, Dr. Pai,
Yes.
what are your perspectives on the role of supplements in conjunction with a whole food plant-based diet for optimizing cardiovascular health? Are there any specific supplements you commonly recommend?
Well, what we look at doing is we look at testing first and foremost, because at the end of the day, supplements are supplementing the diet, not replacing the diet, right? So although, we want people to transition to a whole food plant-based diet, that doesn't mean, and if all three of us right here on this panel ate the same foods every day and even took the same supplements, our nutrition will be completely different in terms of our testing, because that's how we're unique individuals, right? Our microbiome, how we absorb, assimilate, and excrete is completely different. So what we have to do is we have to measure those things, and then based on their symptoms and based on their conditions or diseases or imbalances, as you want to call it, then we would custom formulate and say, what would someone need, right? But a lot of times we're trying to reduce the redundancy that a lot of people take products and they have good levels, right? But what we're trying to do is we're trying to fill in the gap where they're missing something. And more importantly, then teach them like you can get it from the food if you eat more of these things so that you also get the proteins, the phytonutrients, the antioxidants, and the fiber as well. But if patients, there is certain things like if they have blood pressure like CoQ10, or if they have, if people are still on statins because they're either, a super producer or a super absorber, or if they have, they haven't changed their diet yet, for example, or they're just at risk because of other reasons, then, like things like CoQ10, but even measuring those things, even measuring what form or type of those things and what we provide, that has to be like clinically evaluated and then recommended. There's a lot of natural herbs and supplements that we can give for like blood pressure support and other cardiovascular health, even, nitric oxide production. But those are like individual. I don't like to give just general recommendations, because at the end of the day, we want to make it targeted. Like if you're spending money, we should have a reason of why we're giving it, rather than everybody just going to the store and just buying something.
Thank you. Dr. Batiste, you've mentioned potential for reversing or stabilizing arteriosclerotic plaque through lifestyle changes. What is the evidence? What is the evidence supporting this, particularly in relation to cholesterol management?
Yeah, there's actually robust data, and I alluded to this a bit earlier on as it relates to plaque regression. I think first thing that folks have to understand is that most heart attacks don't happen from areas of stenoses of 70, 80, 90%. That happen from areas of 10, 20, 30, 40%, which means that these are fairly young plaques that are there, and we're looking for what we call thin capped atheroma that's there. And that means that they're prone to erupt and explode fairly quickly, releasing their content like a volcanic eruption and or like a pimple. And so our goal is to stabilize that, reducing the inflammatory burden. And we understand that inflammatory burden is tied to the cholesterol. Recognizing that cholesterol is a complex molecule that is comprised of a hydrophobic core and a hydrophilic outer component that's carrying it, and that embeds inside the wall. And so there is a unique relationship. So understanding this inflammatory process becomes important. So how food plays a role is we understand the power of fiber. We understand the power of dark green leafy vegetables and oats and beta glucan and the dietary nitrates that are there, really to reduce the impact on multiple pathways, whether or not it's from the HMG CoA reductase segment that's there, whether or not it's from the receptor for LDL, whether or not it's from the bile acids that causes the system to go ahead and absorb more cholesterol to create more bile acids. There are multiple mechanisms that our food actually can help stabilize the plaque. We understand that there's lusitropic effects, which means that it allows the vessel to relax. There's the release of dietary nitrates, which allows the vessels to dilate. So there's so many many aspects. If we stabilize it to this minimal degree, that can improve blood flow. And our ultimate goal is not reversal, is prevention of recurrent heart attacks and alleviation of symptoms, which is the ultimate goal. I actually don't care if I see a plaque go from 30% to 40% because that's going to be an inter-operator variability in terms of my assessment of it. I care more about, are your symptoms gone? And can I keep you from having a recurrent event? And so that's what's most important in terms of the process of reducing inflammatory burden.
And if I may add to his discussion, I think what was most important, what Dr. Batiste said, that I think many people may have not understood correctly, that he spoke very efficiently in speaking about, is that it's not the area of narrowing. Like when people say they get an angiogram and they see it, it's narrowing, and then they go and they kind of were opening up those areas. But he's absolutely right. The data showed that that's not really where the area when they're having this kind of chest pain or that intervention when we see people have a stent, although it's indicated if they're having an acute attack, don't get me wrong, but when they go and kind of go on and do it electively, the data, he's absolutely right, is showing that that's not really preventing them from having any long-term problem because it's not in that area of the intervention. And so the key that he's mentioning is like we have to reduce it overall. It's not just opening up the areas that we kind of visualize and think that it's bad. That's what we used to think. I mean, we used to think that, but the data didn't show that, didn't support that. So a lot of that intervention, a lot of the things that he was putting in help, which that was the standard of care. Unfortunately, over time, our patients still came back, right? We're like, well, what's going on? And the frustration now that we understand is that it's more complicated than that. It's not just the bigger or the more closed areas of flow. It's also the little minor ones. But one thing I also want to bring up to that is that when we look at cholesterol as a molecule, as I mentioned in my lecture the other day, it's just that recently in the studies on endarterectomies and when they took out the plaques recently, 80% of the cholesterol plaque also has microplastics in there. And then when we look at where's the concentration of microplastics highest in the environment, although we have it in all foods, even organic tofu that I had this morning, right, in my soy milk, for example, but it's highest and heavily found in animal protein. And again, it's because that's just the bioaccumulation of those things. So now we're not only having a cholesterol problem that we have just for centuries, but now we're also having an environmental additive effect on certain foods higher than other foods. So there's a reason why we should be actually, eating less animal protein overall, not only just from the cholesterol, but now from the microplastics. So even those people who are eating grass-fed kind of animal products or wild caught and free range, they're still finding the toxicity coming from there. So there's another level of like, wow, this wasn't a problem, say 50 years ago, but now it is a problem today.
Absolutely. Absolutely. And not to belabor this one question, but I mean, even when you dovetail into all the multiple pathways, when you look at animal protein, we're looking at the heme iron, we're looking at the impact on the microbiome, we're looking at all the pathways, whether trimethyloxamine that begins to occur and develop and extend into the atherosclerosis. And I think it's so imperative because once again, when we look at the occurrence of an acute heart attack, an acute heart attack happens, and just like imagine, for instance, if I had pimples all on my skin that's here, and one of the pimples, if it explodes, then what are you going to see out of there? You're going to see this white, creamy sort of substance. That's an inflammatory process of dead cells and so forth. You invert that in the lining of your vessels. That's essentially the way your vessels look, with small bumps of inflammation that are all throughout that are there that begin to aggregate essentially that's there. And you're having this mound of plaque that's there. And that plaquing on the edges, when it explodes, that is what triggers a heart attack. Now, you're right. When we would go in and even still, it's like, oh, we should just put stents. We should just put stents, just put stents. That's different. When the body responds to that plaque that erupts, it develops a clot. And so the vessel will occlude. So we'll go in and try and occlude to clear that vessel. That's one thing. It's a separate thing if I go in just because you're having occasional symptoms and I see that there is a stable plaque that's there and I decide I'm going to disrupt it. All I'm doing is I'm disrupting, causing small micro tears on either side. And studies have shown that we have increased risk of heart attacks. So it's not saying that it's evil. It's saying that we have to use it in the appropriate situation. Is when we should use these tools. And we need to always consistently use the appropriate tools of nutrition that unfortunately aren't always given in the hospital during the time folks are inside there with an impaired disease.
Yeah, with Dr. Batiste being busy all the time, I mean, I'm gonna just guesstimate here, so don't get me wrong, but like early in the career we're busy, but even later in the career, he's even busier than before, because the challenges that we thought, which was correct, that we were doing all this intervention, which is needed, don't get me wrong, on some level. The disappointment is, I think, in his practice and in my practice and all these other people, is that the patients keep coming back with problems, because where the intervention needs to be, as he's mentioning, is the outreach before they come to the emergency room and the OR. And the challenge is that there's so much people in the emergency room right now, it's hard to get ahead, right? Like, because there's so much disease. So it's important that we provide them the opportunities, not only when we stabilize them, when he stabilizes them, but it's really about trying to prevent them from even coming to see us if we can in that situation. Where it'd be nice to see him as an outpatient, me as an outpatient, rather than I just had this triple bypass and then now what, you know?
Exactly.
Thank you. Talk about the importance of humor and joy. Can positive emotions have a physiological impact on cholesterol and heart health, or is this just the normal positive, upbeat thing that people say? I mean, is this a scientific thing? Is this a documented thing? Is this factual, or is this just everyone says have less stress and have humor and joy, and it sounds good, but really we don't know if it's true?
Yeah, so I'll jump in and start off. So, in terms of, I'll tell you, as it relates to research surrounding joy, humor, positive attitude, there is significant correlative data that tells us that there's an association with longevity beyond a shadow of a doubt, that there's an association with a lower blood pressure, an association with a reduced cardiovascular events in individuals who take time to laugh, who take time simply to smile, and lowering their blood pressure. All these avenues, when you start to break it down from a physiologic perspective, that's here. Yeah, we can talk about the endorphins, but we understand that what begins to happen is there's a diminishment in terms of the stress hormone. There's that begins to happen for the cortisol, and we have seen in terms of in certain studies that have been done looking at the endothelial function. Once again, everything goes back down to that endothelium, right? The lining of the vessels. You all aren't using these Teflon pans anymore, but you remember the Teflon pans that don't allow anything to stick to it? That's your endothelium, a single cellular layer that prevents and repeats out all the harmful things until it gets damaged. And so you're looking at the health of the vessel based upon that. And so we know that the vessels begin to dilate just when you start to laugh. We understand that all of a sudden the mood begins to lift, and there is power that's there from this response. Now, studies have shown why the endothelium is so important is that studies have shown that when you look at endothelial health, it's predictive of diabetes, it's predictive of high blood pressure, it's predictive of future cardiovascular events, even before a person develops severe onset of these things. And so that tells us this process from head to toe, our entire body is comprised of vasculature. And so the importance of humor and laughter playing a role on that is so powerful that I will tell you, after I start looking at the research and I talk about that, that's the H in selfish from my book, is humor. I literally started to play when I'm in the hospital rounding. I will play a comedy show that makes me laugh while I'm reading studies after rounding. I will play inside the car driving home after tough cases or meetings all day long, a comedian that makes me laugh. And I'm sitting there laughing. I'm not watching them. I'm paying attention to the road now, but I'm laughing. And all of a sudden my mood begins to shift. I find myself no longer wanting to watch the horror films and the action films. I want something that is uplifting. And so there's a unique connection between our mindset, our mood, whether or not we look at laughter yoga, all right? There's so much evidence when we start looking at the data surrounding this that it's, once again, all the things that count that can't be counted, but count so heavily. And laughter and humor and purpose in life are one amongst those.
Thank you.
Yeah, I would say the same thing, and even more so like when I see cancer patients and the data that we evaluate with cancer patients is that, when we have laughter and joy, when people are in that kind of state, we know that their heart rate variability is more balanced and more cohesive. We see natural killer cell functioning increase, right? And inflammation decrease.
Mhm.
So, like when I remember when I was in college, there was a book that was written, Anatomy of an Illness, I think, by Norm
Mhm.
Cousins, whatever, right?
That's right.
He had cancer, and then he used to watch the Three Stooges or something way back then. I was like, dating myself and himself, but more importantly. But it's like, that was be like my Seinfeld of today or my generation kind of thing. But it's like those things making him laugh, making him laugh. And it's like, yeah, that's one way we need to bring back that way of helping lower, we know that we're lowering inflammation when we're happy and when we're laughing and joyous. And unfortunately, now with the disease and also with social media, sometimes people go down the rabbit holes. Like they want to become, overachievers at being successful at overcoming their disease. Don't get me wrong. But sometimes that's also a browbeating. They're not taking that time out to just enjoy, again, like what he was saying, Dr. Batiste saying, is like getting out in nature or being with the community or having, love and relationships and connections. Sometimes we become really isolated because we're so much, into that study of like, this is what I need to do. And that becomes inflammatory in a sense, and that actually suppresses the immune system functioning. So I don't think there's anything controversial about that. I just
No.
think that we need to focus more in doing that because I always feel better when I'm laughing rather than crying. So it is something that we just don't have exposure to. And I think sometimes people think it's a waste of time. Like it's not strong. It's not chemo. It's
Mhm.
not an IV. It's not my statin lowering my heart disease risk or blood pressure. But it is something that when we look at longevity studies and we look at blue zone people and all, then happy or even places that, happiness factors is higher, their overall comorbid conditions are the lowest. Like they have
Yeah.
less, they have longer longevity and less problems with chronicity. So I think everybody should have more laughter.
I'll tell you the crazy part is so when we go into these communities and we do blood pressure screening, occasionally I'll tell you more frequently I see the blood pressures are sky high, and I'm having a conversation. But I will typically tell a person, in addition to having them visualize a nice, peaceful, relaxful place and take their breath, do breath work, I will actually try and make them laugh, and we'll engage in laughter and simply smiling. And I've done this time and time again to show students who work with us. The blood pressure goes down. The blood pressure goes down. That simply smiling can help lower the blood pressure. And it may vary according to the individual, but I'll typically see anywhere from several points down to up to 10 to 15 points when they take time to rest and then come back with that. So there is a lot of power as it relates to these simple things in life.
This is for both of you. You've both worked extensively in diverse communities. Are there specific considerations or challenges related to cholesterol and heart disease in these populations?
Do you want to go first or want me to go
Oh,
first?
go ahead.
So one, thank you for asking the question. What I'll tell you is that when we look at disparate communities, I think the first thing I like to say, because there's different connotations that have come into play over the past several years as it relates to discussing disparate communities. As an interventional cardiologist, here's my analogy for those out there listening. When I have patients lined up, outpatients and inpatients to do angiograms, I have my outpatients first. But what happens if a patient becomes very unstable and they have what we call an ST elevation heart attack? They're having a massive heart attack. Well, it's not that I'm showing bias by addressing that they're in peril. They're in immediate risk right now because of the surmounting amount of disease was happening. And I will address that first. I typically will address the issues of disparate communities because of the fact that I see that there are segments of the population that have an astronomically increased risk of events. And what I find that there is this natural overlay that we have. Not only are we having life stressors that are surmounting many of these individuals, whether it's financial, educational, environmental, et cetera, that's increasing it. Now this is put in a crucible of conflict that it's now the match is lit with nutritional deficiencies. That these individuals, we say, will make a better choice, but what surrounds them? They're surrounded by environments where there is only food deserts and food swamps, where they have an absence of health promoting foods that we talk about. They have an absence of, they have an overabundance of overly processed, refined carbohydrate foods that are there, that they're living in areas that are environmentally are unfit. There's no green spaces or environments that are there. And we wonder why there is this continuum of disease. And as studies continue to amount, we start to see that there is an epigenetic transformation that begins to happen in these individuals that can be passed on generationally. And we're seeing this surmounting large amount of disease. So when we look at cholesterol from the foods that are fried, that are over processed inside these communities, it's no surprise why we see that. Now, when we look at the national statistics, we look specifically at places like, American Heart Association statistics, you don't necessarily see it pan out in terms of the cholesterol panels that you see this disparate inside of Hispanic and African American communities and indigenous populations. But part of it we have to look at. These studies are not looking at apolipoprotein B, which is a much more predictive measure and metric for adverse events. They're not looking specifically at C-reactive protein that's reported. Typically, it's looking at total cholesterol, perhaps the low-density lipoprotein cholesterol content, not the particle size. And so the fact that we don't see it, but yet understanding that we see a disparate number of individuals with increased lipoprotein A, which is highly predictive of increased events, it combined with the C-reactive protein, that's what leads to this chasm, to this ignition of disease and disparities that impacts all of us because it's draining the healthcare system. And that we have to kind of stop doing the same thing over and over and expecting a different outcome. And part of that means we have to drive our attention back to the beginning of where all this starts and go up the river and pull these and figure out why people are falling in, right? And once we figure out why they're falling in, we can stop trying to collect bodies at the bottom and figure out and say like, oh, there's just something wrong with them. No, let's take care of the point up top.
Thank you.
Yeah, what we see is, I'm from New Mexico, so we're the 48th poorest state in the country, right? I think we're ahead of Mississippi and Louisiana. Yeah. So not saying much, right? But the problem is it is, we are living in a food desert. We are a very poor community. We have lack of just primary care. It takes usually 9 months to get in to see a provider in my state. So if someone gets seen right now at the heart, has a heart chest pain, they get stabilized, they get discharged from our hospital. It can take 9 months for them to have a follow-up appointment with the cardiologist in my town. Right. And this is in the main city, in the biggest city in the state. Right. So if you live outward, which most people do, then there's a whole loss of follow-up because it's almost a year away and they may have already an event before then. So economics is the other issue, right? Being in a poor state, then we don't have the availability of not only just food deserts, but even of the food stores that we get. They're going to be leaning more towards packaged, processed, cheap, because that's what we can afford as a population. And the economics is there that it pushes people on lower incomes to then drive it through a fast food and say, hey, well, I can get a bucket of this for $20 and feed a family of four because I'm only making $30,000 as a family, low income family because we don't have good enough jobs to pay for. So it becomes this like vicious cycle of keeping people in rural America, I would say, in a perpetual, downward spiral of where these industries, which is both fast food and insurance companies and all stuff like that. It's not, I always tell my patients, on one level, it's not by default that you're here, is by design, right? Like we design these places, we put in these restaurants, we put in I mean, in my state, on each corner of almost every street on both sides is a pharmacy store. Literally like a Walgreens, CVS, almost like, but grocery store way ways, or maybe an exercise fitness place or a community center way ways, but everywhere because it's easy about dispensing a drug, right? But there's people who make financial money off of that, and we have to see like why are we then driven to have higher premiums, or why we're not getting insurance companies? They're just dropping our state in general. Right. So then we don't get primary care. So it's a huge difference when it comes to economics of different populations. So the key that I believe that Dr. Batiste is talking about, and also here, is that we have to go earlier down into the education. And I like to just motivate my patients because of economics. Most people end up changing their diet in my practice when I just Americans just have this attitude that we don't want to be screwed, right? Like we don't like it when someone's cheating us. And if I can explain it, because it's not just about cholesterol and inflammation and microbiome and deficiencies and toxicities. Yeah, okay, that kind of goes over some people. Doesn't, but when they feel like they're being cheated, and it's like, hey, do you know that the top 11 insurance companies owns, so much money in each fast food restaurant. I wrote about that in my book, that there's a financial interest every time they go get a bucket of this, and then they got to go pick up their statin. It's owned by the same people now, making money on the disease and the treatment of disease. People get very angry, like, well, that's not good. I'm like, no, it's not good. Like you need to break the cycle. because everybody's depending. They have the projections that you're going to continue doing this. And so it is an educational step. And we take people hand by hand and slowly teach them how to shop, teach them how to read labels, do cooking classes as much as we can go. And then things like this, educating people, say, you know what, I am going to eat less of that, or I'm not going to eat that at all. I'm going to open up I'm going to go eat the produce aisle, right? Rather than the fast food aisle. And so that's it makes it more of a challenge though, because these patients, with that stress, it's higher, right? It's higher. So the ease is like it's easy to grab something that's more convenient. And I think Americans all around America is the convenience is killing everybody.
Absolutely. Absolutely. No, I'll just echo that. Just additionally, a touch more is that I'll tell you early on in my journey, and I've been at this, doing this for a little bit of time. I remember I was just kind of come up and stand up on my pulpit and tell people inside the clinic, you need to transform your diet. All right. And you need to go whole
Yeah.
food plant-based and put everything out the way. And I remember I walked in the office and I was saying that to this patient and they kind of looked at me and they just said, Doc, I live in basically a 500 square foot apartment.
Yeah.
I have cockroaches inside my apartment. I can't have that stuff. And I stopped in my tracks. I settled down and I got outside my little scripted vibe and I sat down with him. And I remember going through, okay, here's what we're going to do. We're going to buy canned beans. We're going to get the sodium free or low sodium. We're going to buy BPA free. We're going to get frozen rice or frozen grains. We're going to get frozen vegetables that have staying power. We're going to make bowls. That was my first, without reading anything about bowls, my
Yeah.
first concept of bowl method. And really saying, let's go ahead so you can maintain your culture and allow convenience to work for you.
Yeah.
And I didn't stop there. What I said is, okay, you know what? Fine. There's going to be moments, you're a truck driver, when you're out and about. Let's look at all the places where you go to try and make the best option that you can. Meeting a person where they're at and helping them to make slow improvements. Now, of course, I want him, the goal is, as I tell everyone, 26.2 miles is a marathon. I don't start everyone running 26.2 miles on the first day. It's a build up for some. Some people it's a lot faster, others it's a little bit slower, but we have to address individuals according to where they're at, according to their culture, according to their resources, and according to their need and their desire.
And one thing I'll follow up on that is that I think there's a misperception that has been perpetuated on the internet and also I think mainly on social media is that eating healthy is equating to expensive food, right?
Yeah.
Because that's just kind of what it is, right? Because people think, but really when you go back to the basics of what most cultures eat, rice, beans, legumes, lunch, it's like the cheapest per pound.
That's
Like
right.
you
That's
can
right.
get dried beans even cheaper, right? Or rice and all. But we've made it like, oh, I need to get some kind of kale chips or something. Like it's been perpetuated because we're celebrities
Yes.
and social media stars and stuff like that. But really, you have to remind people like, what did their grandparents used to eat in a way?
That's right.
Or culturally, what do we used to eat? Like, and then it's like, wow, I just remember like they didn't have to go to Whole Foods. They didn't have to do this, they didn't have to do that. And it just to remind them like health food does not have to be expensive. Now we can make it expensive and we can buy more expensive foods. People also can go to a whole paycheck and drop $200 on a bag of groceries, or you can go to a farmer's market. And if you don't have that, then you can still get frozen, like he said. There's a lot of ways that people want to just always be like, well, it has to be organic sprouts, and you got to have sprouts to only be healthy. I'm like, my patient, I don't even think we have Sprouts in the store. We have a market called Sprouts, but they don't even think I think they even have Sprouts in the store, right? It's like there's a marketing aspect. It's like, oh, it's Sprouts, and they're just getting their regular foods. I think it's important to us to also remind people that food doesn't have to be expensive, and there's
That's
ways to make food more equitable and fair access and easy for people to use and buy.
absolutely.
Okay, thank you. Dr. Pai, you stated that plant proteins are generally anti-inflammatory. Are there any exceptions or plant foods that are there plant foods that can be pro-inflammatory for certain individuals, or are they all anti-inflammatory?
So two things in general. Plant foods are anti-inflammatory in general, right? They lower inflammatory markers, right? So CRP, IL-1, IL-6, IL-12, IL-17, TNF alpha, all go down. Now, where it can be pro-inflammatory is two things. Number one, if the patient has a food sensitivity, that's one of my areas of specialty. If you read my book, everybody knows why I wrote the An Inflammation Nation. But what it is that some people can have a sensitivity to a food, like an allergy in a sense, and that's triggering an inflammatory response, even if it's coming from a plant. So I always tell people your immune system, does not know the difference. It can say, it's not going to say, oh, this is an egg and this is a kale. It's going to look at things basically due to the microbiome dysfunctions, and it can then say, this food is, I can trigger an inflammatory response now within an hour or delayed up to a few hours, up to 4 days later. We look at all the foods. So I'm an equal opportunity like offender or investigator. I want to look at everything and say, is something coming in your diet, animal, plant, vegetable, legume, grain, or seed, or anything like that? Is it coming in and triggering inflammation? If it is, we got to remove that, and there's ways to rotate that back in the diet, but we're trying to just bring inflammation down overall. Now, so food sensitivities can be from a plant, by the way. And I always tell people where I see people having problems is when they come to my office and they're switching over to plant-based, or they've tried plant-based and they go, oh my God, I tried this and I got worse, my stomach, my this, my that. And then when we test them, it's like, oh my God, you're sensitive to kale or blueberries. And they're like doing blueberry smoothie bowls and all these things. So it's just triggering more inflammation. So we want to pick those foods. Second thing is that too much omega-6s is pro-inflammatory as well. And we get the omega-6s heavily, highly found in the vegetable oils, fried foods, right? Now, we're not no oil, by the way, but America is all about pouring oil, frying oil, dipping everything is too much oil. And that's an omega-6 on top of the meat and dairy and all stuff like that. But that also triggers that inflammatory response coming from a plant food. And again, a lot of what I call unhealthy plant-based eaters are like fried foods, French fries, a lot of the younger kids are just eating fried foods like that. That's not also healthy. That's pro-inflammatory, right? So it may not have the cholesterol per se, but it's pro-inflammatory still, increasing the risk of having other cardiovascular factors as well. So that's what I would say in terms of inflammation.
Yeah, I love that, and especially from the standpoint when we look at seed oils and the omega-6, as you said, rightfully so. The bulk of them are inside the ultra processed foods,
Yeah.
right? And that's where the harm is. When we look at that, that packaging is so imperative, and I think we have to look at that. And I think that's high in the media right now. Of do we substitute out seed oils? Everything's comparison, right?
Right.
Is a saturated fat to cook in a saturated fat better than a seed oil? I don't think the studies point, and they are consistent with that. The studies point the opposite way. You don't want to go that route. But if I'm using whatever inside of ultra processed food that's refined and extracted and so forth, that's extremely problematic as a whole. And I love in terms of the idea of really honing in on the inflammatory component of a specific food. And we know that at a large scale, we look at the degree of lactose intolerance and what begins to happen. That's society, that's across globally, an issue that's there. So, that can trigger a level of inflammation and problems with individuals across the board. But I agree wholeheartedly. I think the other caveat is that we have to make sure that when we speak about plant proteins, we're speaking about the whole food. Once we kind of go to ultra refined protein powders and isolates, we may start to see slight difference in variables that are there too as well.
Thank you.
Yeah, I agree. I think going back to the oils, one thing that I mentioned in my last lecture was there was studies done in Europe looking at all the oils and looking at the increased risk of insulin resistance or blood sugar problems, right? What causes intramyocellular lipid formation in the tissue. And out of all the oils, from canola to olive to avocado and sunflower, safflower, palm oil was the worst. And so when we consume palm oil, that actually will increase insulin resistance or blood sugar problems because it has trouble getting into the cell when we're moving and exercising and whatnot, higher than any other oil. The problem is palm oil is the cheap oil of the decade. It's in every ultra processed snack food, fried food, cookie, cracker, even vegan butter. Doesn't matter. It's in everything. And we see as they've introduced that now into certain communities and cultures, the rise of the diabetes, especially like in India and stuff like that, because we use palm oil frying in every cracker and chip and cookie, is just exponential. The other thing, though, just to flip on the other side, is that people are trying to say, well, what about the saturated fat, right? But the saturated fats like beef tallow, which seems to be the craze right now, that's the highest in palmitic acid.
Yeah.
Same thing, right? Plus, it then causes saturated fat acid, causing inflammation, causing more heart disease, causing people with cancer risk, stimulating CD36 receptors, which is now the pathway of understanding of mitigation of metastasis. And we've now just discovered that high levels of saturated fat triggers cancer cells to spread. right? So there's lessers, right? Like so is this better than this?
That's
And
right.
but the idea is we want to reduce that, but we don't want to just switch it over. Everybody's like, well, let me just go to something that's natural, but that's not a healthy natural as well.
No.
Thank you. Dr. Batiste, regarding cholesterol, a central topic in cardiovascular health, how does a whole food plant-based typically impact LDL, HDL, and triglyceride levels?
Well, I mean, a simple answer from a whole food plant-based diet is going to decrease your LDL, it's going to decrease your triglycerides. And triglycerides tend to be reflective of your dietary constitution in general and just on a large scale. Obviously, taking out familial genetic dyscrasias that are there, dyslipidemias, but that's going to be the main drivers. It's going to drive all those down. Now, the mechanism that it undertakes to drive all those down is going to be a cacophony of things. And I think I alluded to that earlier, whether or not it's an issue of impacting at the level of the HMG-CoA reductase, whether or not it's at the LDL receptors, whether or not it's at the Niemann pick-like receptor inside the intestines. There are multiple pathways where a whole food plant-based, whether or not you're looking at whole grains, whether or not you're looking at the oat beta glucans, whether or not you're looking at nuts and seeds, all the variables, they play a different role, but there's a tremendous overlap that we see a reduction. Now, with that being said, obviously, the way in which you prepare it is important. Right, and how you're going about. So if you're frying and doing several things like that, you may not glean as much of the benefit as what you otherwise would like to see, but we see this benefit. So roughly somewhere between, I believe the estimates are between 15 to 30%, and it's variable, obviously, whether you're looking at ideas like the portfolio diet, the work out of David Jenkins out of Canada, and looking at the reduction, the similarities to LDL, whether or not you're looking at just a straight Mediterranean, which is not completely whole food plant-based, but when you look at the active components of it, looking at predominance of the vegetables and the whole grains and the fruit and so forth, and less of the meats, you're starting to see the active components, the reduction that's there compared to the standard American diet. So everything is relative. It's in what you're comparing it to that plays such a substantial role in this level of impact.
And I always like to tell my patients at the end of the day, um, eating all the molecules that you see, the phytonutrients, right, that are coming only from plant foods, phyto meaning plant, and there's hundreds of these compounds that we study every day in science saying this is reversing heart disease or inflammation or cancer or blood sugar problems and all the metabolic pathways of all those conditions, whether it's diabetes to heart disease to cancer, helping reducing that. But all those plant nutrients and all the things that we study only come from plants that show that reduction. I mean, there's no beef pill that we give, pork pill, dairy pill, egg pill, chicken. Like the doctor's not writing a prescription for any disease, by the way, A through Z. Like we don't give those things. Say, hey, you need more. And there's never a study saying, well, eat more beef and you're going to have less heart attacks, or eat more, have more dairy and you're going to have less breast cancer, and eat more lamb or pork and you're going to have less Alzheimer's disease. It's just the opposite. So I always tell people to step back a little bit and say, like, what's the data show in terms of medicine coming from foods? And at the end of the day, it's coming from plants. Now, again, there will be comparisons to what, as he said, absolutely. So there's going to be an industry saying, well, the beef is better than pork, and then the fish is better than the beef, and then the chicken is better than this, but they're not looking to the gold standard, right? So it's like, which kind of, is it a frosted donut versus a powdered donut, kind of idea,
That's right.
or
That's right.
Coke and Diet Coke kind of thing, right? But that's like the wrong discussion to have. I always remind people,
Absolutely.
like, the doctor's not prescribing you that, and you're not taking a pill of that, right? You're taking all these pills to reverse what we just consumed, or block or inhibit or whatever. So the idea is that, just kind of going back, like that's why you want to shift more, not about
Mhm.
perfection, about reduction at the end of the day. And so as long as you're reducing as much as you can and your numbers are within the normal limits, then that's as good as you get. Or
Yep.
you can get. I mean, you can go further, but for me, it's like that. My job's done. Like
Yeah, no, I love that so much because I mean that's one of the things I'll talk to folks about is let's focus on what we are eating for our health,
yeah.
right? So I try not to come in. Once again, we go back to your former question, right, about laughter and happiness and joy and outlook. So I take a perspective of let's look from a positive as opposed to a negative perspective. So yeah, I can get into an argument and start to vilify this animal protein, that animal protein. I don't need to talk about it. I only want to talk about the things that are beneficial. the things that are providing resiliency to you, that are helping to support. So I want you to focus. I tell patients, I want you to focus on what's going to provide resiliency. That's going to increase the likelihood your return on investment. Everything you're eating, return on investment. So the fruits, the grains, all these aspects, and build upon that more so than emphasizing all the negative. Focus on the positive, on what you're able to achieve. And I've seen it in practice. And so obviously there's every patient's different. And there's some I need to push completely differently than others. But if I'm giving just a one over type recommendation, I'm telling individuals to focus on the positive things. Fill your plate up first with what you should be eating for your health, and don't tell yourself you can't. And I remember telling that to one person. It wasn't a patient. I was just helping them. And she says, "But doc, I'm gonna be too full to eat the other stuff." I just winked at her. I said, "That's right."
Okay. Dr. Pai, you mentioned that your nutrition test can identify nutrient deficiencies even in individuals following a plant-based diet. What are some common nutrient deficiencies you observe in plant-based eaters?
So I don't find anything that's more specifically in a plant-based than a non-plant-based person, right? What we do, because that's a perception that you're going to be deficient because you're eating this way. And in fact, one thing is that in my non-plant-based eaters, which is most people walking in the door, standard American diet or paleo keto diet, because they're trying to lose weight or whatever the trend might be. One of the things that's interesting is that everybody's deficient in B12, right? So that just tells me that their animal protein is also deficient because they're eating factory farm. 99% of animal protein that's produced and sold and eaten in the United States is factory farm. So if I hear someone like, "Oh, I'm getting grass-fed beef and blah 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 blah," that's just like, okay, that one meal, but all the meals that you eat in all the week and you went out to the restaurant and went over here, that's all factory farm food. All those animals which eat plant proteins to get their protein, which is very interesting. Yeah, that's bioaccumulation in their meat, but when they don't eat, they're vegetarian, meaning actual plants like grass-fed or wild caught. These are all factory farmed in CAFOs. Then they have deficiency. So B12 is across the board. So this is something that everybody used to always argue. Vegans or plant-based people, they need to take a B12. I'm like, everybody we test actually are coming low. So that just tells you our food supply has changed over the last couple of decades. Now, but interesting thing is that it's unique. So it doesn't matter how much they're eating per se. It's a microbiome issue because where you absorb these nutrients in your small intestine and colon is very unique and very specific. So depending on if they have dysbiosis, any kind of leaky gut inflammation, the biggest trend that I do see with everybody, by the way, and this is not the nutrition, this is more a microbiome study, is that they still don't eat enough fiber. Right. So even in my plant-based, people like I get my so much servings and all this stuff. But at the end of the day, 95% of people still in the United States don't meet the recommendation of 30 grams or more. Right. And even plant-based people, because we weren't trained, originally they were able to eventually take off the animal protein off the plate, but they didn't really fill up the plate as much as they should. Because just psychologically, just have, we weren't used to that bowl that he's talking about. Bam, there's a lot of food. We were just like, okay, we took out the chicken and we just, we still had some vegetables and grains and legumes on the side and so maybe some fruits and seeds and nuts. We didn't eat enough. So that's one thing I see that even in my plant-based patients that they're really, really low. Toxicities are high with everybody. So it doesn't matter again, the more plant-based, the less toxicities, but we still get exposure from the tap water, the environment, the foods, and all these other things. So the goal is it's not saying like, oh, you have a deficiency, is we test it because everybody's different. So there's not like, oh, everybody gets the same thing because you're plant-based. It's like, no, you might be deficient in B2 and Columbus might have a zinc deficiency and I might be low in magnesium or alpha lipoic acid is low in my body. Like that's just what it's unique to each individual. There can be some genetic issues there, but usually it's microbiome issues and amount and intake issues.
Thank you.
I love that. Sorry, I'm gonna jump in for a sec here. And so I'm gonna pretend like I'm doing my own interview here for a second. So what do you think? One of my hypotheses is, and so you're much more boots on the ground as it relates to this than I am, is the fact that most of us eat the same sort of food on a regular basis.
Right.
We're very much creatures of
Creatures
habit.
of habit.
And we do not diversify even our plant-based foods, even our whole food plant-based foods.
100%.
Trying out, and so we're not getting the colors of the rainbow.
No.
So I don't mean those Skittles. I mean the actual colors of the rainbow, which limits our potential for all of the nutrients that we all truly need.
The most recent data shows that we need 30 different items in a week. Okay. And the average person eats about 8 to 12. right? We have beef, corn, chickens, soy, wheat, eggs, dairy, pork, or whatever. Even if you're plant-based, for me, it's like black beans and pinto beans and kale and chard and blueberries and
Yeah.
strawberry. So yes, it's healthy, but it's still 10 or 12 things, and I'm missing in that 30 different items. That also includes spices, by the
Yeah.
way, and
Yes.
herbs. And so that's like when I was talking, I'm going to do a whole section on my podcast coming soon, is that, like healing spices. And I use that book as a
Yes.
reference all the time. It's like that's where we're missing, and a lot of plant-based people in this universe, although they're whole food plant-based, they miss the whole aspect of there's 50 spices that you should be incorporating. That is even more medicinal than just the protein and the antioxidants. These are higher concentrations of those phytonutrients. So that's one thing that we definitely need to start discussing and adding to the diet. So it's not just, oh, here, let me just steam this or eat it raw or whatever.
Exactly.
It's like the other thing I just want to finish on is that when we see patients and we move them plant-based, and Columbus said like meet them where they're at. I totally agree with that. We meet them at where they're at with their culinary ethnicity of their diet. So here in New
Yeah.
Mexico, it's like I'm teaching people vegan tacos and enchiladas all day
That's
long.
right. That's
You know,
right.
or
That's right.
or we just had vegan pho class the other day for the Vietnamese, and kind of those
Mhm.
things. But it's not just like three bean salad or here's kale salad. I think that the challenge that we have as plant-based providers and practitioners is that the food, in my opinion, again, I'm a little bit more of a foodie, is that it's boring. Like they
Yes.
don't make it they don't make it what they were craving. Like they grew up eating this kind of sandwich or this kind of pasta or this
Yeah.
kind of stir fry. We need to make it plant-based. And you can, it's easy, but
Hmm.
most people who are pushing plant-based diets, it's like if you tell someone like, okay, go just sprout and juice sprouts, the
Yeah.
compliance rate is going to go down once you leave your facility or your retreat or whatever you're doing. At the end of the day, we're looking at the reality of it. Can this be sustainable everywhere, even in the inner city or in a small little 500 square foot apartment? Is it sustainable? And if it is, then we've succeeded. If we've made it more difficult, expensive, or a kind of this exclusive elitism kind of concept, or boring, it's like, well, this is not satisfying my sensory appealing to my
Hmm.
palate, then it could be all life-saving. They still won't eat it.
That's right. That's right. Those are the
And
only additives that you should be having in your food. Don't have the additives that you can't pronounce, only the ones that come from herbs, right? So I mean that's the most important additives that you can have a part of any meal.
I'm gonna go to his house to eat.
I'm telling you,
Now, some of the other providers on the conference, I'm like, I don't know. I can't just juice all day long some sprouts, or I can't just have food with no
Listen,
oil, no
I,
salt
I,
or
I,
sugar.
I
Again,
have
there's
to
a
be
little
on. I have to be honest. My mother lives with me. I don't live with my mother. All right. And
bit.
so at age nearly 90, she's down there right now as we speak,
Yeah.
throwing down on some collard greens, mustards, and dandelions right there for me, while I can be up here doing this and
There
doing
you
work
go.
right before that.
There you go. My dad's 86. He's plant-based, and it's like everybody's surprised, like, wow. It's like he still has his aging problems, but compared to most people 86, they're like, that's it.
The
I'm like,
blessing.
that's it. Like,
Yep.
so there's a little bit of like, it's good. It's a good thing. It's not, and then the other thing is it's not about perfection. So a lot of people think like, well, can a plant-based person still get cancer? Yes.
Yeah.
Can we still get, a gunshot wound in America? Absolutely. Like there's other things. So they always want to put this like super pedestal, like, oh my God, that one person has this
No,
problem. No, that's not how it works. It's risk reduction. Are
that
they
right there.
lowering the risk of heart disease, cancer, stroke?
That's right
Yes, yes.
there.
We can still have problems. We still have financial stress and economic, family stress,
Yes.
marital stress, whatever, environmental stresses. Yes. So we got to stop taking that, we want to kind of build people up and then tear them down. They
Absolutely.
love that. That gets likes in, movies and stuff like that.
Dr. Batiste, you mentioned the importance of knowing one's numbers. What key biomarkers beyond standard cholesterol do you recommend individuals discuss with their doctors to assess cardiovascular risk, especially those following a plant-based diet?
Yeah, so that's a great question. I think that this is extremely important for everyone across the board. Wonderful publication out of New England Journal of Medicine that looked at cardio-inflammatory biomarkers, looking predominantly in women, but it looked at three: C-reactive protein, lipoprotein A, and apolipoprotein B. Right? Those are the ones that that everyone needs to know. Why? As I describe it, right? So you're looking at, when we look at the calculations from, excuse me, the cholesterol panel, that typically are three measured components. It's going to be your total cholesterol, it's going to be your triglycerides, and it's going to be your HDL. Everything else is calculated from that, and it's an estimate, and it's looking at a rough estimate of cholesterol content. And I always give the analogy, if I had a large beach ball that may be filled of triglycerides, that's different than if I have a small golf ball that is extremely damaging, right? And it's concentrated and it has less cholesterol, but it has enough, less triglyceride, but it has enough cholesterol ester to cause harm. That's problematic. We have to, the marker on each of those is going to be your apolipoprotein B, and that will denote one's risk along with C-reactive protein, the marker of inflammation, along with the fact of knowing your lipoprotein A, another marker for this as well. So that's where I recommend almost to everyone to have at least, your lipoprotein should be done at least once in your lifetime. Your apolipoprotein should be done if your risk is high or you've had an event. Then the adjustment of your cholesterol, if you're trying to manage, you have to have a provider who's comfortable and familiar with the cholesterol profile enough to understand what additional methods need to be undertaken to drive your levels down. Studies have shown less than 150, virtually in the absence of disease, studies are now showing, although they're pharmaceutical studies, looking at the lower the total cholesterol, your low density lipoprotein is, as low as below 55, the benefits. We know in the newborn, that's around where it is. So the question is, how can we get there to have to minimize the impact of atheroma throughout our entirety of our body and decrease the burden of inflammation? So those are the markers I always recommend, in addition to your A1C, in addition to your blood pressure, in addition to knowing what your scale reads to as well, or looking at yourself naked, whichever one is your preference.
I would also recommend, when you talked about the A1C, that's something that kind of gets lost. Because everybody's going to be like, we're going to check your cholesterol. And they're going to say, hey, maybe you don't have a blood sugar problem. We check it on everybody because 70% of America has a blood sugar problem on some level. And so that's the first, we look at that as the first domino of the effect of the inflammatory, because it becomes a systemic inflammatory cascade, not only for cardiovascular risk, but neurological problems, type 3 diabetes, we call Alzheimer's disease, dementia issues, and just like risk of cancer and inflammation systemically. So getting that under control lowers your, that's why diabetics have 4 times cardiovascular problems, right? Especially when it's uncontrolled or super high. But we want to look at the holistic approach. And so looking at vitamin D levels, looking at immune system functioning, making sure thyroid is good, looking at kidney liver function, right? Because a lot of people are taking drugs that can cause issues there. We have to look at, although the cardiovascular markers are important because that's the discussion, but the idea is that we want to look at a total holistic approach, because then everybody else does this. When something goes wrong, someone else thinks that someone else is looking at. One of the interesting things I gave in my lecture the other day was in cancer patients in the United States in the last 5 years. The government has the data, insurance has the data, but the number one cause of death in a cancer patient in the United States is not cancer, it's heart disease still.
That's right. That's
right. So number one is number one, whether you have number 2, number 3, number 4, number 15. So we have a tendency to forget, like even our cancer patients, like we're all over. People always, even on the first visit, they're like, why are you asking me about my cholesterol? What about my cancer markers? I'm like, we're going to work on that. But you have to look at the totality of everything, because when we get people through their cancer, the last thing we want them to do is die from the number one cause, which is what the data shows that they're at risk for, which is what we're talking about, heart disease. But we have a tendency to hyper focus, right? Like, this is the cancer. We're only going to talk about that. And if somebody else should be taking care of it, or we're not worried about that because that's the scary C word. But cardiovascular is another scary C word, right? So we got to make sure that we're always looking at it holistically, coming to that approach.
Absolutely.
Let's assume that someone does all the tests, cardiovascular tests, and they come out terrible. And they say, I will do whatever you tell me to do to improve this. And every number is bad. And they say, I have a pen and a paper. I'll do exactly what you tell me. I'll eat, I'll supplement, I'll lifestyle. Tell me the exact recipe to fix it. So what is the recipe? Assuming you don't like your numbers, they're not good. What exactly should someone do to fix their cardiovascular now that you know that you have problems?
Go ahead.
Yeah. So, essentially we're doing what we've talked about all day today. Right. Yeah. So at this point, I am avoiding processed foods. I'm gonna do opposite way I told you I normally do. I don't start with what you shouldn't do. I start with what you should. But I'm gonna start with where I'm gonna eliminate first from the diet. I'm eliminating ultra processed food that melts in your mouth, not in your hands. I'm eliminating animal protein. at this point in time. I'm eliminating most of the hard fats, whether or not it's saturated fats from plants or if it's from animals too as well. The oils, I'm minimizing those as much as possible. I am increasing my vegetables, my cruciferous vegetables. I'm increasing in terms of my legumes. I'm increasing my whole grains and the berries and seeds too as well to make sure I'm getting omegas inside the system. Now, once I'm doing that, that has to be matched from a holistic perspective, as you mentioned, to outdoors. I need measured amounts of sunlight. Why? Well, because we understand that sunlight will release the dietary nitrate stores that are underneath the surface there that can help not only trigger vitamin D, but also dilate the vessels and help alleviate aspects there. Once I do that, I'm working on their sleep too as well, understanding the relationship between the stress hormones, the insulin levels, the ghrelin, the leptin. I'm working on that component, ensuring as we're working through this process, I'm getting them engaged in light activity. If their blood pressure is up as a manifestation of the cardiovascular disease, I'm having them do isometric exercises. That means they're plank, the wall sits that are there periodically in order to kind of help. That's been shown to reduce the blood pressure almost instantaneously. So once I do all those things, now I'm reassessing, right? So I'm planning, I am executing, I'm analyzing, and then I will adjust. What else needs to happen after that point? So those are the four pillars. You plan, you execute, you analyze. That analyzing means I need to inspect what I expect. Then I adjust accordingly. Now we're figuring out, are there additional supplements that are needed? Or do we have to fine tune what types of foods and increase the amount of the fiber-rich foods and ensuring that they're getting 40 grams of fiber in daily or 50 grams, depending on their man or woman. I'm going down that avenue that's there. And that's typically been my pathway for those patients who are fully on board. Now, once we've done that, the other caveat I'll leave with this is it depends on how they're presenting. Are they presenting in the throes of an acute heart attack, or are they presenting as an elective patient? That will determine the full gamut of what I throw at them versus if we have time to really take our time and go. My goal is to lower the risk first, lower that risk first while we increase all the lifestyle and then take off whatever pharmaceuticals if I have to or any other additives at that point. But my goal is to lower that risk as quickly as possible to give them the best chance.
And let me ask you this. If someone, from all your years of experience and everything you've read, um, both of you could answer this. When people do everything you're saying, what percent what percent do they still have of having a heart attack or stroke? So out of, how much of a reduction in risk will they have if they do everything you're saying? How much of a reduction in heart disease, heart attacks, heart disease, let's say heart attacks and strokes if they do everything you say? Will they reduce it 100% like Caldwell Esselstyn says and be heart attack proof? Or will they only reduce it 20%, 50? Like if we do it perfectly, what's the benefit? How much do we get? How much of a reduction in death?
So I'll jump in first. I don't actually have hard numbers that I can track and report out to you. What I could say, I'm very cautious at ever saying that anything in life is 100%, just from experience in life. Everyone is unique in their experience, their body, genetics, everything of that sort. But what I can tell you is, if I'm looking at everyone doing everything, that needs to reflect and pan out to all their markers, their risk markers, have to all bottom out. If we look at the decreasing of their risk factors, as studies have shown, we know there's going to be a substantial lowering of their risk of cardiovascular events across the board, right? That's what I need. But for me to say, just putting you on the diet alone, that it's going to guarantee it's going to drop it, I need to know how you respond as an individual to that in order to really make that as objectively as possible. And even when that's said, even if I told you it's 50%, 45% reduction, 60%, there still is a 40%. It's never 100%.
Yeah,
Because life exists.
I agree. Yeah, I'm going to say, and just like I'm throwing in numbers again, they're not data. This is like what we're saying. It's about 80% reduction out, and even up to 90% reduction. But that's getting everything right, like checking inflammatory foods, balancing any kind of microbiome imbalance. Eating plant-based. Getting the nutrition optimized. But the biggest challenge, like I think, why it's not 100%, even when Esselstyn says that, I think that's a little bit that's just to get the idea of how important this is. Don't get me wrong. But the biggest challenge that I see right now is the stress level, right? Because everybody right now can be plant-based. Everybody can watch these programs and all. But if they had any money in a 401k this past 2 weeks, a lot of people were having chest pain, right? Or a retirement fund or whatever, right? Stress can cause heart disease in that level, right? Emotional stress, psychological stress, the financial stress, right? So that is something that I find is I think the challenge going forward now in time because there's certain things like, hey, you can eat better, but market going up or going down or a tariff cost, like this is the other things that affects everybody. Whether where you live, like this, things are more expensive. That adds an extra burden. And then the lower the income that we have, or the poor the state, or the income that we have, that's a higher burden of us having to pay more. So that's another stressor on top of causing more inflammation. So I think moving forward, we have to look at becoming more resilient to the stress. Because I always tell people, first thing to do is just stop eating things with mothers and faces as much as you can. If it has a mother, has a face, don't eat it. If it's coming from a car window, don't eat it. Like just simple things that start off the board, right? And eat more rainbow colored foods. We go over all that stuff, test the foods. These are the foods you have inflammatory issues. We avoid it, rotate it. These are nutritional deficiencies. Let's fix it. Eat more of these foods, right? Or take a supplement if you need to. Fix the microbiome if there's any kind of dysbiosis, leaky gut, etc. But the stress is still the hardest thing to overcome because we all can be doing great. We can exercise, we can do meditation, mindfulness, and all these outside extraneous factors, particularly now politically and financially, hits everybody. It's the whole country, right? Like literally one day people are like, oh my God, I just lost my retirement, I gotta be doing a lot more work lately. So, and that just creates an inflammatory cascade again, right? So I think moving forward, we have to keep ahead. Like, so it's like making sure that you're getting all of these things as solid as you can, not perfection, but reducing that and being prepared because there's going to be more and more challenges, environmental challenges, financial challenges, political challenges ahead. That's going to affect everybody, regardless of what we're eating. And so we want to just stack up on the good areas. So make sure like, well, my heart disease in terms of my lipids and my blood sugar and my blood pressure is under control because there's other things that are still going to be aggravating those factors to potentially increase it. That's not necessarily a bad thing coming here, but a bad thing coming, mind and body as well.
Thanks.
Right.
Gabriel Cousins said that he recommends we have a teaspoon and a half a day of salt. And he said it's not table salt, it's like salt from a mineral bed that's very high quality, with 92 minerals in it, no microplastics, no explosions, really the highest quality. But he is saying that yes, we need a teaspoon and a half a day of this super high quality salt, followed by water. There are other people that have said salt is positive, and there's a bunch that have said don't have it. Do you, regarding strokes, heart disease, where do you each stand on this?
I'll let you go first,
Okay.
Doc.
So going back to, I've not found, so all salt, especially if it's a sea salt or a bed of salt that's coming from the ocean, has microplastics. That was the study that was just published. So I don't know where the secret is coming from. Interesting thing is, even when they're getting it from the mines, because that's where I like to get Himalayan salt, right? But so they actually found salt in the Himalayan mines. Like, well, how's this for Himalayan salt? But then when we dug deeper, is that they've done studies showing that the Himalayan, quote, I put this in quotes, that was coming from Pakistan, which is the source of it is, that's contaminated sea salt with pink coloring, right? So there's layers of complexity to food adulteration now. It shouldn't really come from the mine itself, but there is also ways that they're processing that can be also plastic parts and things that are coming into the salt. But in terms of just culinary eating, just some Himalayan salt, which if you can get some really high quality that's coming from the mountain, not coming from Pakistan, India versus Pakistan, probably. That's beneficial. It has minerals and stuff like that. But I don't think you need to take it like a teaspoon, like directly for that spoke. We just use it culinary. Right now, too much salt, like table salt and all that, and from my perspective, I see it's causing blood pressure, swelling, particularly packaged salt that is in all frozen food, even vegan foods. That's just the universal cheap, preservative that increases all sorts of problems. And the people are getting way too much salt in packaged, processed, and particularly frozen foods across the board. We do see people we do something like called Soleil, which is that, that's what they use in Europe when people have low blood pressure, that they can take, and that's written in my book. I won't get into too much detail here because I don't want people to go and do these things. But, you can increase when people have low blood pressure to kind of bring it back to balance. And also people have high blood pressure, bring it down to balance. But that's the purposeful thing of doing it a specific way. It's not just taking a teaspoon of some kind of high quality salt. Now, Gabriel Cousens also is doing raw and doing fasting and all these other things. So there might be some reason for all that. But again, looking at the practicality, does the people that live the longest take a teaspoon of salt 3 times a day? I just look at it like going back to the people who live the longest and the healthiest. Are they doing what some of these providers are practicing? And if they're saying they're eating plant-based, yes. If they're doing a colonic, I don't not heard about that. I haven't. Are they doing coffee nibs? No. Are they doing tablespoon of salt or a teaspoon of salt 3 times a day? No. Is it potentially harmful? That jury can be out on that. He might have some data or some personal experience, but I have to look at like what's historically being used, and then what do we still see in the science today? And I don't think that they need to do that.
Thank you.
Yeah, I think that's great. And just, I mean, I think I just want to draw to everyone's attention that a teaspoon of salt typically is about 2,000 milligrams of nearly 2,000 milligrams of sodium, right? So you have to be careful really in the amount that you're consuming. Why? Well, we look at the impact on the endothelium. There's a great review article that came out. It wasn't looking specifically at pink Himalayan salt or other specifics. They just described it in terms of salt. They didn't specify, but looking at the impact and impairment of the endothelium and the triggering of various vascular phenomenon. So I do caution. I'm not saying that everyone who has is going to lead to heart failure or have kidney dysfunction and so forth, but I caution, and I think we want to make sure that as we plan, we analyze, we execute, plan, execute, analyze. In this analyzation, we're looking at what the literature tells us. I think literature, if there's literature to support a table and a half of a special salt, I'd love to read it and review it. You see what's that?
Teaspoon and a half.
Teaspoon and a half. Yeah. I'd love to read it in terms of the beneficial effects on the gut microbiome, the endothelium, cardiovascular health. I'd be very interested in taking a look at that. If it's anecdotal based on your experience, you don't have to have a research for everything. I think that still would be helpful. Look at
Sorry to interrupt, but I would
please.
also say, like, when we teach people how to use food, like in preparation of food, salt is an important part of historical use. And there's documentaries on salt, right? And every culture and there's salt mines and all how we get these certain elements, trace elements in their body and flavorful for foods. But I always tell people, try to buy as many things that are with low salt or no salt. And then you can always add a little bit of culinary salt. You will always add less, by the way. So say someone's getting sunflower seeds. I tell them, get them no salted sunflower seeds, for example, and then because you will always put less, believe it or not, even though it sounds like you're going to put more, you actually put less than that it already comes packaged. So there's ways to actually, get what you need, but reduce it. But I still like to use it more again, but then I'm a foodie. Like, I just cook. Like, why am I taking this like a plain thing, rather when I can make my food flavors and mixing the spiciness, the bitterness, the saltiness, the pungentness, the astringentness, the umami-ness, right? Like, they don't talk about that. Oh yeah, because they're not cooking. They're just raw. Again, I'm eating with Columbus. Okay. I'm not going to brag about anybody else, but I just want to be honest. Like, there's a reason, like, again, the compliance is like this. If I'm living in a retreat center or I live on the land or something like that, and I have a place, that's one thing. I get it. But the average person that he sees in Southern California, another person I see in Albuquerque or anywhere else around America, these are just out of our reach of our daily, like compliance and activity or access or finances. It's just too much. And so we need to give something that's really applicable to the mass population that we can then move. Remember, it's a reduction. It's not perfection, but sometimes it becomes like, I think, too elitism, or too like, you got, plant-based people do this or raw people do that. And it's like, if they want to do that, that's fine. But I don't find that raw people, when we test, because a lot of people come in, who are doing raw diets in my practice, their nutrients are super low. Because your microbiome over time, over evolution, has actually been eating food that's been cooked because we invented fire. People forget that. Historically, your microbiome has evolved to actually eat and process foods that have been cooked. So I understand that they want to get more nutrients, right? But that doesn't necessarily mean that you're getting all the nutrients that you think. And so I always tell people, put it as a test. You come in, they're raw. I got people who juice and do all these things. They're surprised because our microbiome is so unique. So I also don't want people to feel like it has to be so perfect. Everything has to be so like this. And they go, well, how come my test is not perfect? I'm like, because that's how life is. And you're not enjoying your food. You're stressing. You're trying to overcome and crush it or beat it or, fight with it. It's like this should be enjoying, should be nourishing, should bring happiness and community and conversation and lower disease. So anyways.
Okay. Thank you very much. Dr. Pai, how can someone stay in touch with you and follow up with you after this with your books and your website and your work?
So you can go to sanjevani.net, SANJEVANI.net to go to our clinic or our store to look up our book or any of the products like Bosmeric or my book in Inflammation Nation at Sanjevani Store, SANJEVANI store, store.com. And my book's available on Amazon. It's on Audible, or you can order it from our office, and I'd love to sign a copy for you guys. We're available also Wellness, WELLNSNESS, wellness at sanjevani.net, SANJEVANI.net, or 505-821-6300 to make an appointment. I do consultations in person, and I also do telehealth health coaching sessions around the country and around the world. And we also are able to send testing kits and everything, and we can arrange and figure out how to do those things from afar.
Thank you very much, Dr. Batiste. How can we follow up with you, your books, your work? How do we stay in touch with you? Do you do consultations over the computer?
Well, I will first have to say thank you for having me on. I thoroughly enjoyed it, and first opportunity to connect with Dr. Pai, and I've enjoyed our interaction this afternoon. I will tell you, so folks can follow me simply at drbatiste.com. That's DRBATISTE. My book, Selfish: A Cardiologist's Cure for a Stressed and Broken Heart, is available on Amazon, all the modalities, and Audible as well. I don't do virtual consultations at all, but I'd love to connect with you on Instagram. It's at The Healthy Heart Doc. We do speaking engagements. We do events through our nonprofit as well, which is Healthy Heart Nation, myhhn.org. And so this has been phenomenal. I'm encouraged by the number of participants who are on this broadcast right now. You're in the right place at the right time, and this discussion was meant for you.
Thank you both very much for sharing all your years of hard work to find this information out. And if we could unmute everyone so they could thank you as well.
Thank you, doctors. It was very helpful.
Discussion.
Good job. Thank you.
Informative.
Presentation.
I love one more.